Hello everybody, I am Dr. Priti Anand and I'll be taking you through the RR series for the SRH module. I'll be trying to summarize the whole module and I'll start with the FSRH. So the most important thing in this module, in this guideline is to study all of these before you go for exam. With regard to the drug interaction, it is very important because the SBAs come from drug interaction. Please remember that with enzyme inducers, you can't give CHC, POP, and implants. This is a very important question. Also, patients who are taking griseofulvin, in those patients also, as far as possible, CHC, POP, and implants should be avoided. Similarly, if there is any patient who is having diarrhea and vomiting, the oral preparation should be avoided. And if you're planning to give ulipristal acetate to any patient, then after how many gaps, after how many days you should not give any other hormonal contraceptive, that is 5 days. So if you are giving UPA, then hormonal contraceptive should be avoided. Now, missing is another very important topic for our exam. So missing contraception, that is missing of CHC, POP, implants, IUCD, which I'm going to discuss everything. So let's start with the CHC missing. So we know that CHCs, that is combined hormonal contraception, is taken for 3 weeks. Now, if there is a missing of one pill or a patch or ring problem, which occurs for less than 48 hours, there is absolutely no problem if it occurs in any week of the CHC taking. You just advise the patient that take a missed pill as soon as possible, whenever she remembers, rest of the pill at usual time. No additional contraception and no emergency contraception is required. Similarly, she can put the same ring but use a new patch. If any of these problems missing occurs for 2 to 7 days for the patch, ring, or pill, then she has to follow the same format, that is, take the most recent missed pill as soon as possible, rest of the pill at usual time. But if this problem occurs in week 1, there is requirement of additional contraception for 7 days. If there is any unprotected sexual intercourse, then emergency contraception should always be given. If this problem occurs in week 2, then only additional contraception is required and no emergency contraception is required. If this problem occurs in week 3, then the patient has to take the additional contraception, as well as she has to omit the hormone-free interval, but again, emergency contraception is not required. If anything is missed for more than 7 days, then it is considered to be the whole packet need to be started again. So you have to do an urgent UPT if there has been UPSI. You can consider starting any type of CHC contraception with the additional cover of 7 days. And if there has been UPSI, then EC is also required. Missing of if the patient forgets to remove the ring. Now, if you know that ring is taken for 3 weeks, then 1 week gap for hormone-free interval is given. So if the patient says that I'm coming in the next, after 3 weeks, if she's coming in 4 weeks, in the 4th week, and she says that I forgot to remove the ring, you can say to the patient that, okay, no problem, rest of the hormone-free interval you can enjoy. Or you can put a new ring immediately, no additional contraception and no emergency contraception is required. But if the same ring is retained for 5th week, you need to omit the hormone-free interval, put a new ring, use additional contraception for 7 days. But again, EC is not required even if there has been UPSI. If the same ring is retained for more than 5 weeks and there has been UPSI, so urgent pregnancy test need to be done. Consider giving her emergency contraception, omit the hormone-free interval, new ring can be given, and additional contraception for 7 days with follow-up pregnancy test. Missing of POP pills is again important because it has a very small window period of 3 hours for traditional pills and 12 hours for desogestrel pills. Again, if anything happens after that, then you have to tell to the patient, take the most recent missed pill, rest of the pill at usual times, additional contraception for next 48 hours. And if there has been UPSI after missing of pills or within first 48 hours of starting a new pill, then additional emergency contraception need to be given. For IUCD users, if she comes that the thread is missing, first do the examination, check for the threads. If required, you can do a pregnancy test, but definitely first thing need to be the ultrasound to look where is the IUCD. If IUCD is there in the uterus, then you can leave it till it is due for removal. But if it is not there, then you have to do a pelvic X-ray, pelvic and abdominal X-ray to locate whether it has perforated or whether it has expelled out. Similarly, if implant is missing at its site, first of all, an ultrasound needs to be done to see where is the implant. If it is there, that means it has gone deep inside and it requires an removal under a expert center. If it is not visible on ultrasound or X-ray, then you have to do an etonogestrol level to check whether the levels are there in the sera or not. If they are in the sera, that means the implant is there in the body and you need to consider MRI to locate it. But if the etonogestrol levels are not there in the serum, that means implant was never inserted in the body at the time when the clinician did it. DMPA missing means when the ideally DMPA needs to be repeated after every 13th week. But it has a window period of 1 week. So after 14th week, if the patient is coming for repeat injection, within first 14 weeks of giving, you can repeat it by from 13 to 14 week anytime without any additional contraception, without any emergency contraception. But after 14th week, if she is coming, then you can repeat, but definitely make sure that if she is coming very late, you need to rule out the pregnancy. If that is excluded, then with the emergency contraception and additional contraception for 7 days, you can repeat the injection. Bleeding with contraceptive is something which is very important because every contraceptive has some bleeding irregularities when it started. First 3 months is all okay, but definitely if the patient is coming to you with the irregular bleeding pattern, even in the first 3 months, try to rule out STA, cervical screening, and any type of pregnancy. After 3 months, you need to definitely rule out the pregnancy, STI, and cervical screening, but you need to examine also. If there is abnormality, she requires a referral to the gynecologist. If there is no abnormality, then you can start with the medical management. Make sure any patient who is having, apart from the irregular bleeding pattern, she has pain, dyspareunia, heavy bleeding, she's 45 years or more, and she's less than 45, but she has risk factors for endometrial cancer, you need to assess her before giving her anything. Medical management for any type of hormonal contraceptive, if there is an irregular bleeding, you need to start with the CHCs. Basically, if the CHC patient is already taking and she has additional problems, then you can increase the estrogen dose. With POP, if there is a problem, you can either change from brand to brand. That means if she was earlier taking desogestrel and now you can change to POP. But if that is not helping, then you can add on the estrogens. With implant, injectable, and intrauterine system, you can start with CHCs given continuously with them for 3 months. If the patient has any contraindication for estrogen therapy in any of the groups, then you can either use mefenamic acid or you can use tranexamic acid during that period. Emergency contraception is again a very important SBA and EMQ for an exam. Please remember, whenever you are looking what type of emergency contraception patient can be given, you need to make out from the question, when was the last day from the unprotected sexual intercourse? Where in the cycle she's coming to you, whether she's pre-ovulatory or post-ovulatory. Is there anything mentioned in the question with regard to the BMI, enzyme inducers? If they mention that the patient will not accept the coil. So these are some important things which you need to make out from the question, because they require any type of emergency contraception which you need to give has to be on this ground. Please remember, with regard to efficacy, for example, if the patient is fit to take any of them, and you can give either copper T, UP or LNG, then according to the efficacy, always copper T is best, followed by UPA, followed by LNGEC. This pattern has to be followed in the pre-ovulatory phase. In post-ovulatory, that is after day 14 and after day 14, ideally copper T is the one which can be only used in these patients, because UPA and LNG basically delays ovulation. But if ovulation has already occurred, because one of them do not even impact when the LH surge has occurs. So if the LH levels are increasing and ovulation has already occurred, UPA and LNG will not act at all. So that is why copper T is the one thing which has to be used in the post-ovulatory phase. With regard to unprotected sexual intercourse, copper T is helpful until 120 hours, same as UPA, but LNG up to 72 hours of UPSI. With regard to weight, copper T has no problem. UPA avoided in the patients who have weight more than 85 or BMI more than 30. LNG is ineffective if the BMI is more than 26 or weight is more than 70. But if it is required to be given, it can be given in a double dose of 3 milligram. With enzyme inducers, copper T has no issue. UPA is avoided. LNG is also avoided. But if required to give LNG is the only option there, then LNG can be given in a double dose. UPA is also avoided with proton pump inhibitors and glucocorticoids. After delivery and in breastfeeding for up to 28 days postpartum, copper T is absolutely contraindicated. UPA, if you are planning to give UPA to any patient who is postpartum as an emergency, she has to avoid breastfeeding for 1 week. So as far as possible for breastfeeding mothers, UPA is never a good option. LNG has no contraindication, so can be given anytime. Now, coming to the failure rate, this table is very important. Do go through this table because sometimes an SBA may come to your exam. And please remember, the least failure rate is with the implants. So it is considered to be the most effective type of contraceptive. Contraceptive after pregnancy? Yes, after pregnancy, if you are for first 21 days, they say if you do not give anything, then also it is okay. However, if the patient wants anything, you can start anything. For example, CHCs need not to be given for the patients who are breastfeeding up to 6 weeks. CHCs are not given for non-breastfeeding mothers up to 3 weeks. But if the non-breastfeeding mother is has risk factors for venous thromboembolism, then CHCs are not given even for 6 weeks. With regard to coils, coils can be either inserted within first 48 hours of delivery. If not, then up to 28 days postpartum, they are contraindicated. Now, what all can be given? Immediately after delivery or after 21 days if she is coming to you, you can give POP, implant or DMPA. With regard to efficacy, if the patient says, I want something which is most effective, then implant is considered as a best one. Similarly, after miscarriage, abortion, GTD treatment, ectopic treatment, you can start the contraceptive either immediately or at least start it within first 5 days. If you are planning to start anything after 5 days, then you have to use the additional cover form accordingly. And same is for postpartum full-term delivery patient. If you're planning to start anything within first 21 days, you do not require additional contraception. But after 21 days, if you are giving anything, then you have to give the additional contraception cover. Now, for abortion and miscarriage and ectopic, anything can be started anytime. There is no indication for any of them, except if there is any abortion sepsis, then coils should be avoided. But after the GTD treatment, please remember, until the HCG levels are negative, you will not give the coils, neither a copper T nor a LNG IUS system. Rest, anything can be given even if the HCG levels are high. There are various health risks and majority of them are actually related with the CHCUs. So venous thromboembolism risk factors, the patient should be avoid using the CHC. Similarly, if the patient has any history of migraine or she is hypertensive, as far as possible, CHCs should not be used. Any patient who is a smoker and is aged, preferably do not use CHCs. Any patients who is a breast cancer survivor, all the hormonal contraceptions should be avoided. Similarly, is a patient with hepatocellular cancer, hepatocellular adenoma, decompensated cirrhosis, all the hormonal preparations should be avoided. SLE with EPLA positive, contraception of choice is copper T. CHCs fall in the absolute contraindication category and rest all are UKMAC2. Any patient who is very young and is obese, that is less than 18, BMI of more than 30, she is at risk of weight gain with DMPA. Also, any patient who is less than 18 and more than 45 years, there is increased chances of bone loss. So DMPA as far as possible should be avoided. Few words about the drospirenone containing new POPs. Because it is a drospirenone containing POP, it has some mineralocorticoid properties. So as a result, in the patients with the hyperkalemia, untreated hypoaldosteronism, if the patient is on potassium-sparing diuretics, as far as possible, drospirenone containing POPs should be avoided. They should also be avoided in the patients who are having renal insufficiency or acute renal failure. Vishnu? Vishnu?
Yes, ma'am. Yes.
I'll start from this slide. I think it was showing that internet is unstable. I'll start again from this slide.
Uh, okay, ma'am. So we have to cut it down, right, ma'am?
Yeah. This slide,
Yeah.
actually, it was showing it is unstable, so it won't have come.
Okay.
Can I start?
Yes, ma'am.
Okay. Drospirenone containing POPs are something which are new. They are actually have a long window period of 24 hours, but they have some restrictions. For example, they need not to be given in individuals who have renal insufficiency, acute renal failure, if the patient is on potassium-sparing diuretics, aldosterone antagonists. So as far as possible, they need to be avoided in these group of patients. So because it has a window period of 24 hours, if it is missed for more than 24 hours, then we say that it is missed. And how to manage that? Again, take the most recent pill, rest of the pill at usual time, additional cover for 7 days. And if there has been OPSI, then you have to give the patient EC. Now coming to the another topic, which is the BASH one. So BASH, whenever you are reading, make sure you read everything related to this for your exam in these topics. So causes of urethritis and cervicitis, please remember what type of organism they are. They often ask you that Neisseria is a gram-negative diplococci. Diagnosis, 3 of them requires a NAT test by vulvovaginal swab, which can be even self-collected. Neisseria treatment is ceftriaxone, chlamydia treatment is doxycycline, and mycoplasma, please remember, doxycycline for 7 days followed by azithromycin for 3 days is a treatment. But if the patient is macrolide resistant, then patient needs to be given moxifloxacin for 7 days. Okay, it has changed from 10 days to 7 days in a new 2023 guideline. So do remember moxifloxacin for mycoplasma, uncomplicated mycoplasma, it is 400 once daily for 7 days. That is a new addition in 2023 guideline. Then test of cure, they often ask you for Neisseria, all the patients will undergo. For chlamydia or mycoplasma also, all the patients will undergo test of cure. But for chlamydia, please remember poor compliance or very young patient or the patients who are pregnant, only those patients will have test of cure. They often ask the treatment of Neisseria, chlamydia, and mycoplasma in pregnancy. So remember, Neisseria treatment is same because ceftriaxone is safe in pregnant also. Chlamydia, doxy is not given. So either erythro or azithro or amoxicillin need to be given. And mycoplasma, doxy you will remove and azithromycin you will give. Types of vaginal discharge, there are basically 3 types: Candida, bacterial vaginosis, and TB. So the most common cause of vaginal discharge in reproductive age group is bacterial vaginosis. Again, it's an SBA for any exam. Candida and BV are not sexually transmitted. Trichomonas is. In 3 of them, bacterial vaginosis, usually it is a clinical diagnosis because they are very, the specific color and nature of the discharge, and because like BV, if I say, it does not cause any erythema or discharge, any soreness, rest both of them may cause. BV is diagnosed basically by EMSERS criteria. Again, EMSERS criteria is asked in your exam. With regard to treatment, Candida is treated by antifungals, and BV and TB both may be treated with the metronidazole. Please remember, any patient who is breastfeeding or pregnant or BV and trichomonas you are planning to treat, it is always preferable that you treat it with the local application gels. So 0.75% gel comes, which you can use. For trichomonas, they often ask you that what is a test which should be done to diagnose. So it is wet mount preparation, where you see the flagellated protozoans. Whereas if they ask you most sensitive test, then it is a NAT test. Trichomonas is one of the infections where vaginal discharges, the causes of vaginal discharge, where the sexual partner needs to be treated, even if you are not testing or if you are tested, but the results are awaited. That is a very important topic. Ulcers are basically of 2 varieties, painless and painful. So granuloma inguinal, LGV, and syphilis are painless ulcers. Again, for granuloma, donovenosis, they often ask what is a causative agent. So it is Calyphytobacterium granulomatosis. Another name is Klebsiella granulomatosis, which is considered as a newer name. 3 of them are painless, and treatment for granuloma and LGV is for 3 weeks with SZ and doxycycline respectively. And syphilis, you all know, it is benzathine penicillin. Painful ulcers are HSV and chancroid. They often ask what is the causative agent of soft chancre, soft chancre, that is chancroid. So it is gram-negative cocobacilli. It is Haemophilus ducreyi, which causes soft chancre, another name chancroid. And treatment definitely for antiviral, that is acyclovir for herpes, and SZ is required for chancroid. PID treatment, basically most of the patients require an outpatient treatment with ceftriaxone stat dose and doxy and metro for 14 days. Patients who have pyrexia, surgical emergency, TOEPSIS, peritonitis, or they are intolerant to oral drugs, or if they are pregnant, then intravenous therapy, they are admitted. Intravenous therapy is given at least for 24 hours after till the clinical improvement occurs, and then you can switch them to the oral therapy, making sure that the total duration of 14 days they complete for the therapy. Coming to HIV in pregnancy, again, a very important thing for your exam. HIV treatment in pregnancy depends upon the viral load. So if the patient is already known case of HIV, then you can talk with the HIV specialist, because most of the drugs are actually safe except dolutegravir. Dolutegravir you need to stop till 6 weeks of pregnancy. But if the patient wants to continue, you have to give her that. It carries a high risk of neural tube defects, which is again an SBA for your exam. Now, if the patient is diagnosed in pregnancy as HIV positive, when to start the antiviral? So if the viral load is less than 30,000, you can start in second trimester. If it is 30,000 to 1 lakh, you can start at the start of second trimester. And if the viral load is more than 1 lakh, then you have to start it in the first trimester as soon as possible. Do remember, if the viral load is, you are not checking the viral load, or the patient refuses for any type of testing, then ideally all the patients need to start CAR therapy by 24 weeks of pregnancy. And tenofovir with amitriptyline or abacavir with lamivudine and a booster of adzanavir with efavirenz can be added in, both of them respectively as required. Now, mode of delivery, it depends upon the viral load at 36 weeks. So if viral load is less than 30, your patient can plan the vaginal delivery. If it is 30 to 399, cesarean section should be considered. And if it is more than 400 or equal to 400, then exactly planned cesarean section in between 38 to 39 weeks should be done. Similarly, if the patient presents with spontaneous rupture of membrane, same criteria needs to be followed. For PPROM patients, you can follow the same criteria, but give the GBS prophylaxis. And if the patient has very preterm baby, less than 34 weeks, and steroids and everything needs to be given, but delivery plan will be by the MDT team. Now, they often ask you these days that if the patient is born, the baby is born, what is the prophylaxis for the baby? So it all depends upon the maternal health, and we have a criteria that some babies will be very low risk. For example, if the mother was on card for more than 10 weeks in pregnancy, her viral load done twice 4 weeks apart, and it was less than 50, and when she delivered, her viral load was less than 50, either at 36 weeks or at the time of delivery. So these babies are very low risk, requires zidovudine monotherapy for 2 weeks. If none of these criteria are met, but the viral load is less than 50 for the mother at the time of delivery, or if the infant is born premature and mother's viral load was less than 50, then 4 weeks zidovudine monotherapy should be given. And if none of these are followed and the viral load is either very high, or if the viral load is unknown, then 4 weeks triple therapy should be given. Few questions that is commonly asked in your exam, that HIV screening. Vishnu?
Yes, ma'am.
Vishnu, I'll just stop for a moment. I have a patient.
Okay.
So there are few questions which are important for your exam. For example, they often ask you that if the patient has come for antenatal visit and she declines that she'll not undergo HIV screening. So we respect her wishes, but again, we'll offer her the same test at 28 weeks. They also ask you what is the risk of HIV transmission if the patient have a needle prick injury with somebody who is either a high risk for carrying an HIV or somebody who is tested as HIV positive. So in this case, the risk is 3 per 1,000. Again, a very important SBA for exam. There was a question in your exam once that there is a patient who is basically it is an exam tested question. So the patient has come to you, the doctor was performing some surgery and got a needle stick injury with somebody who has known to be HIV positive. So in that case, please remember, if anybody who gets basically an injury by somebody who is known HIV or unknown HIV but carries a risk of HIV, and the risk of transmission is more than 1 in 1,000, then as soon as possible, the patient who got the injury should be treated with the exposure, post-exposure prophylaxis started within 24 hours, can be offered up to 72 hours, and a full course of 28 days should be given. And usually, what is the combination of drug? It is tenofovir, amitriptyline, and raltegravir. Ultra-rapid HBV vaccination and testing should be done. So some baseline tests like HIV, HBS, AG, STI screening, syphilis, etc., RFT, LFTs need to be done. And some of these tests like HIV and HBS, AG should be repeated after 8 to 12 weeks. Now, if the syphilis is tested and if the syphilis, all the tests aren't coming as negative, but she carries a full-blown symptoms and symptomatology and presentation of secondary syphilis, usually these patients are, the test which is coming as negative, this phenomena is known as Prozon phenomena. If patient has rheumatoid arthritis and you test that TPPA is negative, but RPR is coming as positive. So some patients of the chronic diseases like rheumatoid arthritis, like tuberculosis, they have actually the test like TPP, RPR or VDRL comes positive in them. So these are known as false positive testing. And if the patient is a known history of syphilis with TPPA positive and EIA or CL, RPR, EIA is also positive, but RPR is negative. So these are actually the cases of very early syphilis. So these are some explanation for the same. And for the syphilis testing, ideally the first test to be done is always a IgM or IgG, basically antibody detection test, which can be EIA or CLIA. But if the first test is positive, patient requires a confirmatory test, which is usually done by TPPA or TPHA. So for the syphilis testing, the first test EIA, CLIA, if you are doing, and if they are negative, then you repeat only after 3 months for the high risk category. If they are positive, then you need to do a confirmatory test. So on the same sample, you will do a different test, that is TPP and TPHA, and another sample you will take and repeat the first test. So EIA and CLIA are repeated on the second sample again, but on the second sample. Once these are positive, then the patient will undergo the quantitative test, that is RPR or VDRL. And if she is pregnant, then you'll involve everybody, the gum clinic, the pediatrician, and make a syphilis birth plan. I have also seen a question these days, very commonly asked, that the patient has syphilis and she is basically having birth plan is made. So they ask you that at what gestation you complete the treatment. So she is at the least risk or she is at the highest risk. So if she completes the treatment within 10 days of delivery, last 10 days, she's, according to this question, she is at high risk. Because ideally, if the patient suffers syphilis in pregnancy, she should complete the treatment 30 days prior to delivery. So then the baby is considered to be the low risk, at very low risk. So this is basically a syphilis birth plan, which says that either the patient did not have syphilis or treated syphilis prior to getting pregnant, or if the treatment was completed well before the delivery, then the baby does not carry any risk. And just you see the baby and the detailed examination, nothing is done. So in the no risk infants, basically, Vishnu?
Yes, ma'am.
I'll just start from this slide again, syphilis birth plan.
Okay.
So syphilis birth plan is a question in your exam. I have seen this question in your exam. Did I ask you that how much is the risk for the... Just a moment, dear. Just a moment. I'll go back to the question. Actually, I need to remove... I've seen this sometimes there is a question, or it is very important to know that syphilis, if the patient suffers from syphilis in pregnancy, how much is the risk to the baby? So the risk category, basically they divide the baby into no risk, low risk, and high risk again. So if the mother has received treatment for syphilis well before she got pregnant, so mothers who have adequately been treated for syphilis before pregnancy, who have not been reinfected, carries the no risk for the infant. Babies whose mother has been treated adequately for syphilis during pregnancy and completed the treatment well 30 days before the baby was born, appropriate doses, and her titers are also very low, then the baby is a low risk. High risk is anything which is not no risk, and low risk is a high risk. So no risk babies usually do not require any examination and testing. Low risk babies require examination as well as testing. And high-risk babies require the detailed examination, detailed testing, and the treatment. So you have to make sure that you know that any patient who has been pregnant and has a syphilis being treated in pregnancy, as far as possible, before 30 days of baby is born, the syphilis treatment should be completed. Then the baby is considered to be the low-risk infant. There may be a question in exam that if the patient, because we know that syphilis is treated with benzathine penicillin, but if the patient is sensitive to penicillin, but if she is able to tolerate cephalosporins, then ceftriaxone can be given. If the patient is not allergic to penicillin but does not require any intramuscular injections, then amoxicillin with probenecid can be given for 14 days. These questions may be asked in your exam, that if the patient is syphilis sensitive, then and the options are given that what else you can give, then ceftriaxone is one of the options, because it's not necessary every time the patient is penicillin sensitive, so cephalosporins also it is sensitive to. And definitely they'll mention in the question in detail everything. Again, a very important question for your exam, that if the patient has syphilis in pregnancy, how to manage it. So benzathine penicillin for the early syphilis, and single dose for the, if the patient presents within first and second trimester. If she's presenting in third trimester, then 2 doses. And for the late syphilis, any trimester she comes, she always need to receive 3 doses of benzathine penicillin weekly for 3 doses. So thank you very much, everybody. Thank you so much. It is a quick revision of SRH module through the StudyMEDIC RRR series. I hope it is helpful to you, everybody of you. Thank you so much, and all the best for your exam. Thank you so much.